All right, so now where we're going with functional anatomy, what's left actually, because we did the upper extremity, lower extremity, we're moving into the trunk and spine. And I typically, when I teach the functional anatomy aspect, I just did it this semester to keep everything as easy as possible. But I teach trunk and spine first, and then move from there because the core, the pelvic, the spine, the shoulder girdle, all of these things influence the extremity movements. And if you noticed when we were talking about hip function last module or last unit, we kept on referencing the pelvis and the spine, and so they're intricately involved. What we're going to look at here is we're going to look at the pelvic girdle in terms of its relationship with the spine. We're going to look at the cervical spine and the head. We're also going to look at the jaw, and then we're going to look at the thorax, and the thorax involves spinal stability, transfer of forces between the shoulder girdle and the pelvic girdle, and then mechanical movements for respiration, ventilation. And so there's a lot of different things that are tied into this next unit, but they kind of integrate in. And the amount of muscles you have to know are significantly reduced because the muscles here are looked at upon as groups. It could be complex if we look at the individual muscles, but we're going to look at them as groups instead of their isolated function. For instance, the transverse spinalis group, which includes the spinalis, the rotors, and the multifidi muscles, we'll understand those muscles from an individual aspect, but in terms of looking at who's contributing to trunk rotation or spinal flexion, we'll look at them as their collective grouping instead of the individual components. Whoops, I just hit stop video, but I want to start video. I want to share screen. Okay, so this is kind of probably be the most confusing module, not so much that the material is confusing, but the way that I'm going to present it's going to be different than the textbook. The textbook has the TMJ first, and then it has the neck and the trunk, and then it has the respiratory system. What I'm going to do is I'm going to break it up a little bit where I'm going to teach the thorax, the thoracic spine, and the lumbar spine and how those interact. And then we're going to do head and neck together as a whole. So we'll look at the jaw, and then we'll look at the cervical spine. And then as we're going through the thoracic aspect, we will look at respiration and the muscles that are involved in that. And we might pepper in, we're going to pepper in posture with this as well because everything's interrelated. So we're going to cover all the material. Just when you look at the videos and you go through the lab aspect, they're going to be broken up just a little bit differently. Today, I'm going to start with the TMJ, the head and the neck, or at least the jaw part. I'm going to follow the textbook, but the lecture videos are going to be grouped together, similar to how when we had like hand and wrist separate or foot and ankle separate, but then sometimes together. But this one is going to be picking and choosing a little bit from the different areas. TMJ, or the temporomandibular joint, but TMJ issues with this particular joint itself is a fairly common area that's treated within the realm of physical therapy. There are jaw dysfunctions. So much of it's related to the cervical spine, and as we'll look at, like the cervical spine and the head starting position influences the jaw. And really, you're looking at a joint here that articulates between the skull, the top part of the skull, and you have the bottom part of your mandible. And when you look here, you would have your cervical spine right here. Let me see if there's another image of that. I happen to have a cervical spine. Pull up. It's funny. I just need a head and neck image. Well, needless to say, when you look at the head, when you look at the top part of the skull, its stability is founded on the cervical spine. The cervical spine is founded on the thoracic spine, and then all the way down the chain through the pelvic girdle and down through the legs. And so when you have disorders of the head, particularly when you have people sitting a lot, or you have people in screens where they start to have this forward head posture, this starts to change the functional relationship between the base, the foundation of the skull, the cervical spine, and the head. And if this bone is out of place, if this is not centered, it's going to cause mechanical stress and strain here. And this is not like a joint that we don't use on a regular basis. Everything, when you're talking, when you're chewing, everything is involved with that particular joint. And there's another bone that's involved in this called the hyoid bone, and it is not really a functional joint. I'm actually looking over at my skeleton there, and I guess it broke off there. It's your Adam's apple, the bone that's right here. This kind of floats, and it just more separates the around the thyroid cartilage. But the muscles of the anterior neck, so all of this here, they simultaneously are involved in spinal stabilization, and they're also involved in that opening of your mouth. Now, opening your mouth is a motion that goes with gravity, so you don't need a lot of force to do it, but it still is involved in its stability aspect. And then when you look at your exercising, when you're actually trying to teach patients about spinal stability and core activation and appropriate posture during exercise, particularly like squatting or big movements, pulling activities, your jaw, tongue, and head position are all part of that stabilization aspect. And so you can have leaks in your pressure system or leaks in your stability based on as innocuous things as your tongue not being at the roof of your mouth, your jaw not being totally closed. And you get a lot of involvement with dentists and dentistry looking at appropriate jaw alignment. And a lot of times they'll start to modify the teeth. And we're dealing with a lot of aftermath of people that have had braces and orthodontics and different things. You start to change the crowding or the space of the mouth, and you start to change the jaw mechanics. You change jaw mechanics, you're going to change cervical spine mechanics, and then you're going to start that domino effect all the way down the chain. And that's why you have people doing crazy things like, and not crazy things like it's ridiculous, but crazy things like it's quite amazing but effective, that you can change jaw function, like people that have like offset jaw mechanics or they have TMJ issues. And this can be coming from somewhere down the kinetic chain. So you could change someone's like foot placement, like a leg length discrepancy, put somebody in orthotics, and it can alleviate pain in the TMJ aspect. So just because this is a one little single joint and it seems like it's isolated, it has influence both ways in terms of being affected by other things down the chain and can affect things down the chain. So it is a common aspect for therapy. And it's one of those things where you got someone that comes in with crazy jaw pain. You start treating that patient, be aware that you might have to jump ship and start chasing that down the kinetic chain, down through the spine or wherever it ends up leading you. That's not what I want. This is what I want here. So with all that said, you only have two basic things you can do with your jaw. You can open your jaw, open your mouth, and close your mouth. You can protrude your jaw, so kind of give yourself like a sticky nut chin, like so your bottom of your teeth come in front, and you can give yourself a double chin by retracting your jaw, and then you can move your jaw laterally, side to side, lateral deviation. So you can deviate, protrude, and open and close. All of these motions are happening all the time. It's just that we isolate these in exaggerated like sagittal plane motion, frontal plane motion, transverse. But every time you open and close your jaw, you're getting some lateral movement. And then in the process of eating, we're not as obvious as cows when they're kind of chewing their cud back and forth, but we do some lateral movement to kind of realign food in this aspect. And now what's interesting about the TMJ is that it's a capsular joint, right? It's a diarthroidal joint, but it doesn't have like this really obvious socket that moves in. And typically when you have joints, you have the moving bone that's kind of connecting with the stable bone. In this case, the skull is the stable bone and the mandible is the moving bone. But most of the joint architecture is actually on the jaw itself. It doesn't really sit into a socket like the disc and everything is actually connected to the condyle here. It's not really there in the skull itself. And people think a lot of times people mistake the auditory meatus here, where this is the ear canal, but there's not really a socket or anything for this jaw to articulate. It's really a functional joint that's kind of floating there, held together by connective tissue and musculature. Let me zoom in here a little bit. So you can see right here, right there, there's a little notch that's cut out, but that's there for muscles and other connective tissue to come along. Let's see if we got a view of the mandible. Mandible's up here. Most of the joint is on the convex surface of the condyle, and all the connective tissue is here on the mandible. It's external, if you want to look at it that way. It's more of the moving aspect. And this is also the axis of rotation. You have the body of the jaw and you have the angle of the jaw. And the reason why I'm pointing out these particular landmarks is that when you look at jaw function, you're going to be looking at the angle of the jaw moving posteriorly, moving back as this is opening up. And there's two phases to the movement. There's this opening, but there's if arthrokinematics are going to play a big role, it's going to play a big role here in the jaw, understanding the jaw, because as the jaw moves open, as it drops down, there has to be a glide forward that's happening, and the jaw itself isn't moving. The joint capsule, the joint itself is actually moving, and we'll look at some of the musculature that's happening there. One of the things I want to point out in terms of structural anatomy is that we're dealing with a temporal bone here, and the skull has all these fused aspects, but we have this zygomatic process, this zygomatic arch, and I don't think people appreciate that there's actually space there. So you could actually push your fingers down in there, and you can't, because the temporalis muscle is there, but there's a cave, there's an opening there that things come down, and you can you remove that bone, and your temporalis muscle, like right here, if you put your hands on your forehead and you squeeze your teeth, you'll feel the muscle pop out. That muscle is coming right behind that zygomatic arch. So, we see the skull and we think it's one solid aspect, but there's actually openings here on either side that you can tuck things down in there. And then you have the other relevant anatomy of the skull besides the zygomatic arch, the temporal bone. You have the styloid process. Here's the hyoid bone that I was talking about earlier. And you have the styloid process that is acting as an anchor for a lot of the muscles that are the supra and infrahyoid muscles. And these are the muscles that are keeping the jaw in place in the anterior neck musculature. So you have the zygomatic process, you have the temporal bone, and then you have that styloid process that's coming down. Let me see if we can zoom in a little bit more here. So they cut out the zygomatic arch, so you can kind of see behind here, and you can see they have this here. That's the skull right here, temporal bone. There's the process of the mandible, and then you have this articular disc, and it's like a vertebral disc or your pubic symphysis. It's a thick connective tissue that acts as a cushion between the two components here. Because if you think about what's happening, your bite force is quite large. I mean, enough to bite into flesh. And so when you think about when you're chomping down, your teeth are bearing most of that force, but it's a third degree joint, and so you have an axis here, this fulcrum, which is being compressed. And so if this disc is not in the right place, or the disc is off a little bit, this is where patients end up with a lot of problem or pain there, because of the high forces that are involved in your chewing, particularly if you have food like far away from the axis, out by your teeth versus crunching back at the molars. But you can kind of see here, you can see the ligament structure that's here, and it's these ligaments and that joint capsule or that articular disc that make up the joint. So there's not a lot of bony connection. There's not a lot of cartilage surface. There's really just this floating disc, and it's a disc that moves to accommodate that gliding and arthrokinematics. You have a bunch of ligaments here that kind of keep that support. You can kind of see the joint capsule there between the two aspects, and the disc kind of contained within that. You can see the styloid process and the ligament that's kind of keeping the joint in alignment. And then that's it. There's really not a lot of heavy structure here. Most of this is musculature. So here's a really good view. You can see now during the movement, you can see that there's not a lot of you can see the congruency between the process of the mandible and the joint space here of the skull, and that most of the joint is developed by the disc here, and the disc is not like cemented in here or attached there. It's kind of floating. It's like a barrier between the two aspects, and it moves. It kind of accommodate the aspect. And as you open the jaw, so here you see the jaw opening up, and so you kind of see the mandible rotating forward. You can see there's quite a bit of anterior translation that occurs to accommodate that movement. So when you open your mouth, your jaw is actually going forward, which means when you close your mouth, it's coming back. What happens a lot in TMJ dysfunction isn't so much the joint here, is that this disc, you can see that the disc, as you open your mouth, there's tension on these ligaments, and it's meant to pull the disc forward, and there needs to be a synchronous aspect between the process of the mandible moving forward and that disc. And if those become out of sync, what can happen is the jaw can close faster than that is actually happening, and you can get like this disc pinched that's putting pressure, and there's quite a bit of pain here that the patient would sense. And so a lot of times the treatment here is to either like relax these tissues or try to involve like the sequencing of the muscles, what can end up happening is you get inflammation and the capsule. But I think a lot of times it's because of the mechanical positioning down the kinetic chain. But most of the dysfunction is happening with this disc itself, and it's a moving product, and so it lends itself to that dysfunction. And then you can appreciate some of the arthrokinematics here when you look at the lateral deviation. So when you deviate to the left, you're getting stuff, you're getting a spin here. And then as you move to the left, the whole jaw is kind of coming forward and coming in aspect. So when you bring your jaw to your left, the joint action that's happening on the right is the same as when you open your mouth. And the joint action on here is the same as you close your mouth. And then when you do a lateral deviation to your right, so if I stick my jaw to my right, this is acting like it's closing or clamping down. It's spinning a little bit in its space. And then the left side is acting like it's opening. And so sometimes you can, what you'll do when you're treating patients is sometimes you will exaggerate some of these movements. So let's say they have a little clicking or popping when they open their mouth, and it's more on the right side. You'll have them do some exercises to try to go to the left to try to mimic the opening without that disc moving. And sometimes you can reposition or replace that. So you'll probably get this in your ortho in the aspect, or maybe not. This is really maybe too specific. This would be on par with like the TMJ type aspect. There are some PTs that specialize in it, but these are things that you would take like a weekend course, like especially with vertigo type aspect for the repositioning for the otoliths, that you could take like a weekend course and learn how to do some interventions for the jaw. But it's basically playing around with the arthrokinematics and how the jaw is supposed to be functioning with different aspects. But the big takeaway is that you have this anterior gliding with this opening, and the jaw is moving, but the whole joint is coming along with the bone itself, which is not typical of most of the other joints. Most of the joints, the capsule and the articular cartilage was staying still, and the bone was moving. In this case, the whole thing's moving together. It has to be timed accordingly. So we're going to start looking at the muscles of mastication, and you're clearly going to have a lot more muscles that are overcoming gravity, that are closing your mouth, than you will open your mouth. There's not a lot of like forceful, you think about if you put your hands on your chin and you try to open your mouth, you really don't have a lot of force there. If you put your fingers in your mouth and you bite as hard as you can, you might lose a finger. So you have clearly much more force in closing than you do opening. The biggest muscle in terms of broadest muscle is the temporalis. And this muscle it's called temporalis because it's around the temporal region on the sides, right anterior to the ear. And all of the muscle belly gets tucked behind the zygomatic arch. So it's actually going behind the bone here, and it's attaching right at the right here on the anterior aspect of the jaw. Here's the angle, and then there's your process there. That's your one of your largest muscles. Your next largest muscle is the masseter, and this is underneath the zygomatic arch. So right, if you palpate, right, if you kind of palpate right underneath the zygomatic arch and you close, you'll feel that pop up. And you have two heads. You have a lateral and actually forgot the name of that. I was probably looking at it together. Okay, so it's looking at two divisions here, but it goes from the angle up to the zygomatic arch, and this is the glute of the face, right? It's the thickest muscle of the jaw, and it's the primary muscle that's used in chewing. And when you're doing a lot of chewing and you get fatigued, you're typically feeling it there with the masseter muscle. So the temporalis muscle up here above the zygomatic arch, most of the belly contraction, and then the masseter muscle below the zygomatic arch. Those are your two primary muscles for closing down. That's where 95% of your bite force is coming from. You have the pterygoid muscles. You have the lateral and medial pterygoids, and these are internal. So you would actually have to put your hand in your mouth to feel these. And these are involved. These are more stabilizing, but they are involved in closure as well. But it can also be involved in opening, depending upon jaw positioning. And I think you have a better view. Do we have a better view of the pterygoids? Let me switch over. So you can actually, there's a really cool picture. Yeah. So you can kind of see here. This is if you were to take the skull and look from a inferior view, and you can see here's the zygomatic arch. You're looking where the jaw would be. You can see where the pterygoids they attach. So they're kind of right on the inside of the jaw. On the outside of the jaw, you have the masseter muscle, and then this is the space for the temporalis. So the temporalis muscle is coming from the side of the head, and it's shooting straight down underneath this zygomatic arch. You kind of see here that there is a little bit of a dome or a space for the condyle of the mandible to get in there, but that space is filled up with that disc. And there's your hyoid. So here you can appreciate all the positions together. You have a fat pad right there, and then you have your disc. This is just kind of creates some space to make sure the disc doesn't go all the way back. There's your articular disc, and then you have your pterygoid muscles, and you have the ligaments there. And again, as this jaw is opening up, you'll see an anterior translation. So these muscles are pulling on that disc and making sure that as the condyle is moving forward, the disc is coming along with it to kind of create that lubricant system. So it's just a strange joint that the joint architecture that normally is stable is mobile, moving with the bone itself. This is just showing some of the ligaments, and all these images I have in my video. I use these images for the video because I think they, especially when we look at some of these movements. So here you can appreciate the rolling and sliding. So as I open up, this is rolling backwards, and then it has that anterior translation, and you can see the tension on the connective tissue here to kind of keep the disc from going all the way forward. And you have this fat pad here for stabilization. You get a nice view of the temporalis muscle coming down behind the zygomatic arch, and then you can see the big, thick. You can see how thick the masseter is. I mean, it's just a thick muscle. It's most of the bulk of the jaw, and it has it's two heads: superficial head and deep head, and it's right underneath the zygomatic arch, whereas the temporalis is coming down behind the zygomatic arch. And then when I was talking about this lateral deviation, I said that it's like opening on one side and closing on the other. And you can kind of appreciate in this image some of the musculature where when I go to in this case, he's going to the left. Going to the left is like opening for the right and closing on the left. So you have the same muscles, the temporalis and the masseter, that are involved in that. And then you have the pterygoids here that are involved a little bit in opening, and they're kind of pushing the opposite side. So in closing, like chomping down, you're going to have bilateral temporalis and bilateral masseter muscles that are contracting, primary muscles for closing. And then when you're doing lat deviation, if I'm going to the right, it's going to be the same as closing, opening. And if I'm going to the left, it's going to be the same as opening, closing. And this is, I switched over here because we were talking about the pterygoids, and this is just a much better image of the pterygoids. So you have the jaw cut away. So these are behind the jaw. There's the styloid process. The masseter is moved, the temporalis is removed, and you can see the inside of basically this is actually the base or the foundation of the cheek. So if you were to stick your finger in your mouth, you'd hit like the buccal muscles and some of your connective tissue. And as you push in further, you start to get to the pterygoids. And a lot of times when you see a lot of treatment for these muscles, you'll see people putting gloves on, inserting their fingers into the mouth and squeezing to try to work out any of the trigger points or any of the adhesions that might be there in those musculature. And sometimes just kind of massaging that tissue to kind of help realign the length tension relationship to allow more appropriate movement so that the jaw can kind of close. And because that's the issue too when you have the TMJ, is that you might have timing issues from left to right. So as I close, I want to make sure that the jaw is closing at the same time. If one's closing faster than the other, you're going to get a little bit that is a deviation. So the sequencing and timing also has to be. So if you have like an imbalance where you have one side that's tight and the other side that's weak, sometimes going in there and massaging those tissues to relax that to allow that alignment, that symmetry to work. So I really like this image here because it kind of shows the relationship. It shows the temporalis muscle, it shows the masseter muscle, and it shows the pterygoids. And you can see how between all three muscles, it has like a sling system, and you have the masseter balanced out by the pterygoids, and then you have the temporalis muscle that's pulling straight forward. And so this is where a lot of your stability and force comes from. And it gives you maybe a roadmap to look at if you're looking to find out some kind of issues with balance, right? Do I need to work more on the pterygoids or the masseter or and before, yeah, and that's it. So then we move away from the jaw and we get into the hyoid. But here's a really good image because your other book doesn't have it. Here's your hyoid bone right there. And then you have your supra, so above your suprahyoid muscles. And this makes up like the base of the neck. So all this stuff here, the floor of the mouth. And then you have your infrahyoid muscles. And we'll talk more about the infrahyoid muscles when we get in the neck for neck stability. You can see why I do head and neck together because they're intricately related. But you can see here, you can see the omohyoid muscles and a lot of the stability. You should see all the scalenes, and all these muscles are muscles we're going to get to when we talk about the anterior neck and neck stability. But you can see that a lot of these muscles are anchored to the hyoid. The hyoid's anchored to the mandible, and the mandible is anchored via just that one little that disc. And so when you're looking at anterior neck stability, particularly if you're putting this in a chronically shortened position or lengthened, depending upon the upper or lower, the jaw positioning can influence neck stability and vice versa. Neck stability can influence jaw mobility. You know, if you get muscles here that are weak, you're going to get muscles up here that are going to tighten up to protect and limit motion. If these tighten up, they're going to limit motion for opening, and particularly if it's one-sided or not. And you can start getting these imbalances all the way down the chain. So this image kind of encapsulates what I was talking about at the beginning of the session, that jaw issues aren't always jaw issues, that there can be a relationship and effect all the way down the chain. Oh, that's what I forgot to point out, is that when you look at the pterygoid muscles, the medial pterygoids are involved in the closing of the mouth, and the lateral pterygoids are involved in opening of the mouth. And that most of your muscles, most of your muscle mass is in the masseter and the medial pterygoid for closing. And then you do have some muscles for opening, but those are the suprahyoid muscles. And again, gravity is helping out quite a bit with this. If I just relax everything, my mouth opens up. So you don't have that many muscles, but just think lateral muscles are for opening and medial muscles. But most of your chomping force is going to come from your masseter and your temporalis. You kind of see these cartoon images looking at the opening. So as the jaw opens up, you have the pterygoids kind of pulling forward, keeping that, kind of have this anterior translation. That's what's pulling that's the lateral pterygoid that's actually pulling it forward. So the muscle's not so much as opening as it is that anterior translation. And then for the closing aspect, you have the temporalis and the medial pterygoid. Now remember, all of these images are going to be in my lecture, so you'll have the PowerPoint in this, so you don't worry about if you don't have this particular textbook. I just think it illustrates them much better because you can kind of see the angles, and the arrows are proportional to the amount of force being generated. So these are they do a great job in looking at muscle action in this textbook. And I think that's it. So let's flip back over to the other. Yeah, I mean, you look at those images and you come here and look at these, it's like, oh, great, thanks for these great images. So here's a different view of probably a little less busy view, so more simplified. Here's your suprahyoid and infrahyoid muscles. Here's your SCM and your other musculature that we're going to talk quite a bit when we look at like neck muscles. But these muscles are involved in that opening, and then the masseter and temporalis are for the closing. And I think that's it. So yeah, it's a very short little little unit, but nonetheless pretty important when we look at the TMJ. Any questions at all? All right, just for essence of time, since we went through this, I'm just gonna, since we started talking about the neck musculature, I'm gonna just do a quick little tour of the cervical spine of the chapter 15, and just look at some of the aspects for that, so that on Thursday we can play around with some of the jaw and, or I'm sorry, Friday, jaw and neck stability. And so for this particular chapter, I'm going to be jumping around a lot because we're talking about just cervical spine and anything above the collarbone for this particular aspect. And then next week, we'll talk about the thoracic and lumbar spine. And the movements of the spine, regardless if you're looking at cervical, thoracic, or lumbar, are the same, right? You have cervical, you have flexion and extension, either cervical, thoracic, or lumbar. And you have rotation, so either turning your head to your left or turning your head to your right. And you have lateral bending with like bringing your left ear to your right shoulder, or left ear to left shoulder, and right ear to right shoulder. And like I said, we're going to be talking mostly about the cervical spine. But when we look at this retrospectively at the end of the unit, we take a step back. There's no way that you separate cervical from thoracic, thoracic from lumbar. There's just unique things that are happening, but the cervical spine and lumbar spine are intricately related, right? They share the same curves. They're so intricately related that if you end up with a fusion at L4, L5, or L3, L4, 20, 30 years down the line, because of the mechanical relationship, you're going to end up with degeneration here at C2, C3. If you take this out, so the relationship between lumbar and cervical is actually more pronounced than, say, like here or here, like one or two things up. So because of the same curvature and because of the way that the spine is transferring energy between the shoulder girdle and pelvic girdle, there's a very solid relationship between cervical and lumbar spine. But that's just a side note as we move forward here. When you look at the cervical spine, the occipital bone, which is the base of the skull, here's the foramen opening for the spinal cord. And you have your condyles here that sit on the very first cervical vertebra. But the bulk of the neck musculature insert on the base of the skull here. And we have quite a bit of musculature here. And so when we start looking at terminology, when we look at here at the cervical spine, you have 7 cervical vertebrae. So you have C7, C6, C5, C4, C3, C2. Well, you have C0 or CO, which represents the occipital aspect. So sometimes you'll see like C1, C0, or C1, CO. That's referring as the gap that's between the cervical spine, the first cervical vertebra, and the occipital bone of the skull. So like I said, 95, 98% of the muscles attach here. You get some in the temporal, but the occipital ridge is a huge landmark for our attachments. All of the vertebrae have very similar structure. They have the body and they have a foramen that the spinal cord goes through. You have a spinous process, which is the medial protrusion. Then you have 2 transverse processes, and then you have an articular or mammillary process. And all of these points here serve as muscle attachments. And so you have muscles that are filling through the gap here, muscles here, and then anchoring connective tissue or muscles to these processes. Here's where the spinal cord comes through. And this articular process right here, that's the actual joint relationship. So a lot of people think that this is the joint that's between the vertebral bodies, and the movement's not occurring here. That's more of just a transfer of force or cushioning. It's more of a storage form of energy. It's like, think of the vertebral disc as batteries between vertebral bodies. The joint is actually between the articular processes. So this is the superior and then the inferior, and these are the facet joints. All of the spine has these discs, and inside the disc you have like a gel, and this connective tissue is very, very thick and dense. And again, it's a shock absorption, but it's really a energy storage unit for storing rotational energy. So all of the vertebrae are pretty consistent except for the first 2 cervical vertebrae, C1 and C2. C1 is referred to as Atlas because it's the top, and it's holding if you think of the Greek myth, Atlas was holding the world up on his shoulders. And basically that's what Atlas, the C1, is doing. It's holding the entire weight of the head. That's the first articulation between the occipital ridge, the foramen opening, and the Atlas. Just underneath that, you have the axis, or C2, and the reason why it's called an axis is that it has this protrusion sitting up. Well, it's not going to show me that. Let's do this. So if you look here, here's your atlas, right? And these are the articular surfaces that hit those condyles at the base of the skull. And so right there is your very first cervical vertebra, and your skull is kind of rocking on these components. And then what's right on top or right below the atlas is the axis. And so right here is where the atlas articulates with the axis. And this almost all of cervical rotation, like 70% of it, is happening between C1 and C2. And this dens, or this process that's sticking up here, that's the axis of rotation that is on. So when you look at the motion of the articulation between here and the spine, you kind of see here. So this sits on top of that. The C1 spins on C2, and when you look at the amount of rotation, there's here, it's showing it right here. So you can see C1 spins on C2. It's almost like a pivot point, and that's where when you turn your head left or right, a majority of that motion is coming from this joint right here, just that one single joint. You turn your head to your left, you turn your head to your right. You do get some of the rotation through the rest of the cervical vertebra, but it's nothing in comparison to the amount of rotation that's there. Now, when you look at C0 and C1, you don't get any rotation there. The motion you get there is this flexion and extension, right? So you get no rotation at the skull. So when you turn your head, where your skull goes, your C1 goes. But when you tilt your head forward and back, you're getting the movement there at the cervical spine. So that's the only oddball with the cervical. The rest of it, when you look at all the other cervical, thoracic, and lumbar vertebra, you're going to get rotation, you're going to get lateral flexion, and you're going to get flexion and extension. But you have limited motion between C1 and C2 because of their structure and their relationship here. Through here, you can kind of appreciate C1, C2. You can see the motion that's occurring there, only that rotation. So we'll go through the muscles, and that will be it for at least the cervical region of the spine. The video that I have for the articular, it kind of goes more into the mechanics and the relationship, but it's integrated within the entire aspect. But I just wanted to cover all the posterior and anterior neck muscles along with the jaw muscles, and just give you time to kind of look over it over the next couple of weeks. Prominent neck muscle is the SCM, the sternocleidomastoid, and then so it's SCM is how it's referenced as an acronym, and it attaches to the mastoid process of the back of the skull, the occipital ridge there, and it comes down right in front. So it has this diagonal relationship that comes from back behind the ear and it comes all the way down in front below the chin. So it's like at a 45-degree angle. So it's involved in quite a bit. It's involved in flexion, depending upon head position. It can be involved in extension, and it's big involvement in cervical rotation, left and right. Obviously, since it's unilateral on either side, it'll be involved in lateral flexion, but it does quite a bit of movements in terms of because it has this unique orientation. You have your scalenes as a group. You have your anterior, middle, and posterior, and that's based on their insertion points here. You can see the posterior has a posterior insertion, middle has a middle insertion, and anterior. And these are your primary lateral flexors of the neck. These two also, depending upon head position, if you have a forward head position, they're going to be acting as flexors. If you have, they can be acting as flexors initially, but then they can be involved in extension to bring your head back to neutral. If your head is back in extension, they're going to come and play and act as flexors to kind of bring everything back to neutral. So these are more of your like muscles that are involved in keeping your head in neutral. This is looking at a posterior view, and we'll look at a different aspect, but you have a whole set of suboccipital muscles that connect between C2, C1, and that occipital ridge, but we'll get back to that. You have this anterior aspect of the musculature, is very deep anterior musculature, longus colli, longus capitis, and these muscles are basically like what the psoas is to the hip. These are to the head neck, especially that neck flexion. And we get so many people with this forward head posture that we have such a issue with these anterior musculature that these are quite often weak on people. And the way that you usually test for this anterior stability is you have someone lay down like they're going to do a sit up, but they're just going to do a neck up, and they keep their chin tucked into as much as they can, and they try to hold their head up. And you'll find that what people want to do, because this is be the the actively insufficient position, is that you have their head up and they're trying to keep their chin down. They want to lengthen those muscles, so you'll see their chin pop up. And depending upon how long they can hold that, that is a big sign of how weak or how lack of endurance those anterior neck musculatures are. But a lot of times when people are that have neck pain or thoracic pain, a lot of times it can be rooted in weakness in these anterior musculature here. So these ones that are on the spine. So now we're looking at a posterior view, and we're looking at what's called the suboccipital muscle group. And you have quite a few of them. You have like 5 of them, and you have a pair on each side. And these muscles, you can see that most of them anchor on C1. A couple of them anchor down at C2, but they all, except for this guy here, the inferior, they have all their attachments on the occipital ridge. And that's why they're called the suboccipital muscles. And these are involved with fine control of head movement, so your ability to kind of turn your head, look up or look down or look to your right. And that's what these guys are doing, is this is what it gives you your fine control to be able to help. I think it's, let me just take a minute here to explain. It's everything your brain is trying to do in terms of functional mobility is to keep your eyes level to the horizon and keep you focused on a focal point when you're trying to walk. So every time you're walking, your head is turning, you got all this movement, you're running, but your body's keeping your head stable like a gimbal for a camera so that you stay focused on your point. If you didn't have that, you'd have all this extra movement moving around, and it would be too much visual processing for the brain to happen. And you wouldn't be able to track things, you wouldn't be able to hunt things, you wouldn't be able to get away from danger. So you have a whole set of musculature that's there to kind of keep this head stable no matter what position you're in, no matter how I turn my head. I'm able to keep my eyes focused, and it's a relationship between the ocular muscles, the cervical muscles, and then the rest of the trunk muscles. And these suboccipital muscles make a big play in that. And then I think we get into the, yeah. That's it for the small musculature of the neck. You have the SCM, you have the scalenes, you have these anterior neck musculature, these the longus colli, longus capitis. You have the suboccipital muscles, all similar movement in terms of rotation. And then you have the hyoid, the infra and suprahyoid muscles that we talked about in the previous aspect. These are your anterior muscles that are involved in either tongue control, the floor of the mouth, or jaw control, like looking at the anchor of that. And then we start to get into the posterior muscles, which we're going to just talk about 2 of them, and then we're going to hold, and then we're going to get into, we'll talk about the rest of them when we talk about thoracic and a lumbar spine. But you have the splenius cervicus and splenius capitis. These muscles originate both on the spinous processes and then shoot up. One attaches to the skull and one attaches to C1, and that's why one's called cervicus and one's called capitis. Anytime you see capitis, that's referring to the occipital ridge, like the capital, the head, and then cervicus, you're looking at that. We'll tease this out because these muscles are, when we look at some of the neck muscles, these are some of the muscles we've already talked about in terms of shoulder musculature. So like levator scapula, which is used quite a bit in like scapular elevation and downward rotation of the scapula. It is a very powerful cervical rotator because of its anchor on the can't think right now, the transverse processes of the first 3 or 4 cervical spine. Your second largest muscle of the back, the trapezius, has 60% of its attachment to the cervical through the head, like all through here. If we look at the trapezius, let me pull it up. So here, right here is your splenius capitis, and if we were to take that away, right underneath it, you would see the levator scapula, and you can see the trapezius coming up. This is a good image here. Oh, no, that one is too small. We'll go back to that one. you can see how much of the trap is actually attached. So more than half of it is attached to the either the occipital ridge, the nuchal ligament of the cervical spine, and then the transition between the thoracic spine. So it is as much as a cervical muscle as it is a shoulder muscle. And we talked about how much it's involved in the shoulder girdle. And the trap, as large and as superficial as it is, has huge influences on head position. So when we look at like turning your head to your left or your right, remember we talked about trapezius being involved with humeral abduction, and that yes, this is deltoid and some of the other muscles, but you need trap in order to control the scapula. Trap is also when you think of cervical rotation, I'm thinking of trap first between any other muscle. The trapezius, because of its superficial attachment and the size, it is the strongest torque producer for cervical rotation. So turning your head to your left or to your right. And so this is where you start to appreciate the relationship between shoulder issues and your cervical spine and head positioning. And depending upon your head posture, lateral movements, rotational aspects, they're interrelated. So when people have shoulder issues, particularly if they have bilateral upper extremity issues, so like carpal tunnel or shoulder, or I'm abandoning shoulder and wrist and I'm going centrally to the spine to see where can I find that bilateral aspect. I saw a good picture. Oh, here, right here. So here's the levator scapula, right? We looked at it as a elevator and a downward rotator, but you can see that it has its insertion on the C1, C2, C3, C4 on those transverse processes. And again, these are long protrusions, so they have long lever arms. Levator scapula, I would argue, is more of a cervical rotator than it is it's just as much as a cervical rotator as it is an elevator, right? It has huge movement for that. And if this muscle is coming in and being involved as a rotator, if the scapula is not in the right position because of thoracic spine or other issues, it's going to create a chain reaction down the up or down the spine. So the levator scapula and trapezius muscles, which we learned as shoulder muscles, are big players in our cervical aspect. And I'm not going to get into it now, but how we're going to figure this out is that they have different functions. Like they all act as extensors, right? But when it starts to come to rotation, turning your head to your left, they start to have agonist-antagonist relationships. So if I turn my head to the right, this is the agonist and this is the antagonist. Trapezius on the same side would be the agonist, and levator on the opposite side would be the antagonist. So you start to get these paired functions. And there's a whole worksheet that we're going to go through, because like when we look at thoracic spine, we look at trunk rotation. We're going to start playing around with like same side internal oblique, opposite side external oblique. And so that's where a lot of your study is going to go into, is looking at the agonist-antagonist relationship that exists between like erector spinae, transverse spinalis, and all of these muscles that we're talking about in terms of their joint motion. But for now, for today's video, I just want to introduce the musculature and kind of see where we're going with it. You do have the transverse spinalis and erector spinae muscles that come all the way up, but we'll talk about those when we look at the thoracic spine. So like you can see here with the erector spinae, you have a lumbar division, you have a thoracic division, and you have a cervical division, and you have a capital division. It is one long continuous muscle, but it does have different biomechanical functions. So we are still missing some of the musculature in the neck, but we'll get to that when we look at the thoracolumbar region. But that's it. That's the only thing we're missing, is the erector spinae and the transverse spinalis group. These little tiny like interspinally and intertransverse musculature. Perfect. A little long, but I think we covered what we needed to cover. That puts us, I think, right where we need to be to make up for having the exam later this week. And I think we should be good then. Anything else I want to point out? Any questions? Any questions on I saw only 2 people took the practice exam, so I didn't see a lot of people take the practice exam, but was there any questions on those at all? Or I'm going to stop the recording here and